Okay, thanks everyone for being back in time, and we're going to start with our last session of the day, and this is going to be another fascinating debate that will hopefully answer all our questions on this really important topic of should we be treating high-risk smouldering myeloma. And we've got another two debaters, but before we get to them and I'll introduce them, we'll just look at the case to illustrate our point. So this is a 55-year-old woman. She was originally admitted to hospital with acute hematuria, UTI symptoms, but during the course of investigations, her bloods revealed that she was marginally hypercalcemic, but did have a very high total protein unexpectedly. And that led to some reflex testing, which demonstrated that she had slightly suppressed IgA and IgM levels, but very high IgG level, and electrophoresis showed a 24.5 gram per litre paraprotein, which was shown to be an IgG kappa paraprotein. So she was referred to haematology, and when she came to it was completely asymptomatic and had had her UTI treated and felt completely well. She had some completion bloods done at a point where we were just using ISS for staging, and those were the results, so low B2 microglobulin or normal level, and normal level of albumin. And she'd had a bit of further investigation of the marginal hypercalcemia, which had revealed that she did actually have hyperparathyroidism, primary hyperparathyroidism, and you can see there very low vitamin D level. So she had a serum free light chain assay done to complete looking at myeloma markers, and you can see the slightly raised kappa light chain with a ratio of 6.6 overall. She had a whole body MRI, which demonstrated no evidence of focal lesions, and a bone marrow biopsy that showed 27% infiltration with plasma cells with a malignant phenotype by flow, and a similar sort of infiltration on the trophine. And in the genetics, found to have a deletion of TP53 in 70 of the 100 nuclei, but no other high-risk markers identified. So she had a DEXA scan done, which showed she was osteopenic at the hip and the spine, and then she went on to be referred to the endocrine team for that and the hyperparathyroidism. But in summary then, a 55-year-old who presents with no Crabbe-Slim criteria, 27% plasma cell burden in the marrow. You can see there the level of the IgG paraprotein, slightly abnormal serum free light chain ratio, and the evidence of deletion of TP53. So with that in mind then, please can you vote on the best management plan? We've narrowed down options for you for this case. So your options are you can closely observe the patient for a bit longer, you can give them close observation plus some myeloma intensity bisphosphonate, or you could treat at this stage with a high-risk smouldering myeloma regimen. Now, we're not asking what you're able to do in your practice, but what you think the best management plan is, and that's, of course, the purpose of this debate. So if you could state that rather than what you would be limited to by your MDT. I think we're nearly there. Yeah, okay. Okay, interesting. So when asked what you think the best thing to do is rather than what we can do, just under half people would say they closely observe. We've got just under a third who closely observe plus give bisphosphonate in whatever your myeloma intensity regimen is for that. And then just over 20% who would want to treat this patient as they've got high-risk smouldering disease. So that's an interesting start, I think, to our debate. I'm going to introduce the two speakers and then let them have the floor. So arguing for treating high-risk smouldering myeloma, we have Dr. Dean Smith, who's worked as a consultant haematologist at City Hospitals Nottingham since 2015, specialising in myeloma, and more recently he was appointed associate professor at Nottingham University. He's an active member of the UKMS and a particular interest in precursor diseases, and is chief investigator of the investigator-initiated MODIFY trial. He's also a member of the BSH Myeloma Guidelines Group and co-author of the BSH Guidelines for the Investigation and Management of Newly Diagnosed Myeloma. And in the other corner, we've got Dr. Jamal Kathari, who's a consultant haematologist at Oxford University Hospitals, clinical lead for myeloma for Oxford and the Thames Valley. He trained at UCLH before joining the consultants at Oxford in 2014, and as well as myeloma, he has an interest in Waldenstrom's and has led numerous clinical trials in both myeloma and Waldenstrom's. So as you can see, we've got two heavyweights and we now await your opinion about whether or not they're correct for their argument. Thanks.